Thanks for tuning in today. I'm Dr. Nick, the Incrementalist. Join me as I seek out the small incremental changes being applied in other industries that we can learn from and that can be applied in healthcare. Can these changes bring immediate value, but also add up to the big improvements and revolution we need in healthcare? Come along with me to explore the possibilities. My innovative guests from around the globe have used small incremental improvements to achieve their moonshot. And today, I'm talking to Dr. Jay Mathur. He's the Associate Regional Medical Officer for Caremore Health Systems in Connecticut. Jay, thanks for joining me today.
Thanks, Nick. Thanks for having us. Excited to be here.
So I'm really excited to have seen a presentation, learned a little bit about Caremore, and some of the really innovative and indeed incremental things that they're doing as an organization to help manage chronically sick patients and help them both manage those conditions and actually improve their health. Can you help the listeners and just share a little bit of the detail as to who Caremore is and how they go about managing that health program?
Great question, Nick. It's as you said, it is incremental steps, and Caremore is actually an organization that's been around for over 25 years now and has been set up in a way to think about what are those care coordination steps, what are the behavioral health barriers, what are the upstream interventions we can be thinking about when we're in a world where we're incentivized to really think about what patients are going through and what barriers they actually have to care. In California, where Caremore started, they had basically built a medical group asking all the same questions that we ask today, but before it became a buzzword around things like population health, and really built out a model that took care of seniors going through transitions of care, thinking about chronic disease management, having chronic disease management clinics, and really built a successful model that grew to the point where they replicated this model in a Medicare population in Arizona, Nevada, Virginia, and then given that success, they were able to move on to think about other populations in places like Des Moines and Memphis, where we focus on a Medicaid population where, again, social determinants are at the forefront, and it's not more complicated types of disease, it's actually more social barriers that affect their ability to take care of themselves. Connecticut, which we launched last summer, is actually a unique opportunity to deliver home-based primary care for the same top 10% hotspotters, whatever the terminology we like to use. We partner with a health plan here locally, which gives us a bunch of advantages around using data to find the right people that need this level of care where you have an interdisciplinary team involved. So, we launched them a year ago, and we're, happy to answer any questions about how this plays out in the home environment and then Caremore at large.
So one of the things that I pick out of that's unique and interesting is the fact that Caremore and your team go after the hardest patients. That's right?
Yeah, we lean into this population, and by having the right people that join us and that are a part of our team that take care of these patients, we're able to meaningfully engage patients in a way that once you break out of the world of fee-for-service medicine, where you're having to see patients every 15 minutes, you can actually think about a population at large and which 10% of your patients needs 75% of your time. You can really be creative around the types of people you employ. And so we double down on social workers, case managers. We have navigators that come from the communities of where our patients come from. And, the care plan execution is delivered by them and not necessarily by folks that may not be able to communicate in the right ways with patients or understand the barriers they're going through. And so, given the fact that we can partner with a health plan, we can fix payment, get it out of the way, we can really start to think about what it is that our patients need. And so, I think that pointing out that relationship between the healthcare providers and the health insurance is critical to being able to deliver this type of care.
So tell us a little bit about the team. What's that made up of in your particular instance?
Yeah, I started to allude to it, and it starts with I almost like to think of huddle actually as the way we start our day and the different lenses and different roles the different folks play when we come into work every morning. Huddle is a sacred 20 to 30 minutes we spend every morning getting organized around, one, there's the schedule for the day, but more importantly, there's a list of patients that we're concerned about and who's doing what to engage this patient or set of patients when we're, of course, once we start the workday, there's a ton of things going on, but how can each person maximize their impact on a patient that we're concerned about? And so clinical partners, that's the name for our medical assistants. They're like medical assistants on steroids. They come with, we're training them around motivational interviewing. They do things like blood pressure, vital signs. They help set up transportation. They'll go and teach how to use a nebulizer. I like to think of them as the glue, the front lines of kind of really engaging patients where they're at. At the same time, behavioral health is clearly at the forefront of what's going on for most populations, not just the sickest 10%, but the set of behavioral health issues that our patients face, it's not uncommon: anxiety, depression. We have social workers on staff that do short-term therapy up until a point. They do a needs assessment, will triage whether this is something that has a finite endpoint. Is this something that requires long-term therapy? And if that's the case, we've sort of plugged into the community here and know who would benefit from which type of behavioral health facility. We actually have a psychiatrist on staff that we consult for an hour a week around med management. Often as a confident generalist, which is the types of providers we like to think of ourselves at Caremore, I often need a pat on the back around, hey, this is this antidepressant I want to start, or hey, this is what I want to tweak. And to have a psychiatrist on board to think about some of those medications, that's extremely helpful. But I do think the hardest part of interventions are the therapy components. So our social workers own that. We then have case managers who are accountable to everything happening from setting up DME equipment to the highest complexity patients on our panel. Where are they right now? They are the face of our care model to the hospital systems. They'll show up for our patients when they're in the hospital and make sure that everything is organized before discharge, communicate really well with the team at Huddle around what we need to be thinking about at that hospital discharge follow-up visit. And then you have the providers who I mentioned, where we're out of the world of fee-for-service. So guess what? I love doing steroid injections, and I do them in shoulders and knees at the home for osteoarthritis and Medicare populations, and patients love it. And we can be really thoughtful and push the limits of what we do as a generalist, and that's the team, and that's what we do every day.
So that team, you talk about the huddle and the sort of foundation of that to sort of set things up, I guess, for the day. But then that team disperses, and do they go together to the patient's home, or is this an individual approach? Is sort of divide and conquer? How does that play out?
It's a great question, and so we've iterated on this a couple of times, learning and doing at the same time here in Connecticut. And we start every journey with Caremore at a healthy start. At the healthy start, a medical assistant / clinical partner and a provider will go to the home, introduce the care model. There's a series of things from just signing consents to talking to screening for depression and food insecurity to doing a physical exam to reconciling medications. It's a pretty comprehensive first visit that often winds up being split into two with the complex patient that you may have. And so we think it's really important to have as much of the team interface with the patient up front. And so even down to having the case manager call within 5 days of that initial visit, we lay it on thick, if you may, to start with their journey with Caremore. And then moving forward, follow-up visits are often done by the provider, by a physician or nurse practitioner. And then, if there's something as simple as a blood pressure that's slightly abnormal, our clinical partners will show up to do a repeat blood pressure check. They'll FaceTime me and talk to me while they're in front of the patient to talk about what next steps should be. They're teaching them about nebulizers, diabetic teaching. We have a case manager that'll come asynchronously to us to make sure, we're always communicating, but, it's after that those initial touch points, we do sort of communicate and have these touch points asynchronously.
So you talked about the clinical partners, those medical assistants, as being the glue. How do they hold everything together? What's their sort of strategy for that communication? How are you making sure, aside from the huddle, which is the start, but obviously subsequent to that, lots of things happen. How does it all get back, and how do people get, maintain that coordination? And importantly, how do you get that back to the patient through all of this, who are obviously, limited in terms of their access to traditional technology and, some of the things that we all expect in, privileged circumstances, but these typically, they don't have access to that.
Yeah, and I mean, you hit it on the head around, like, communication is the most important thing. And so I'd almost even go back to the HR side of things. And we really believe in human capital here at Caremore, and get hiring the right people that believe in team. I have a series of, how I screen for a team player, to just being able to effectively communicate, trying to mock, you can't get it 100% right in an interview, but things on a resume, after a certain point, like, they all, things look very similar. And I really just want to know who the person is and how they thrive in an environment like this, where, there's ambiguity as we're going out into the home, and, not every home is the same. Not every person is the same. Not every teammate is the same, or will they come to work in the same? Our teammates can have a bad day. How will you handle that? And so, from a communication perspective, it's hiring the right people, and then it's putting iPhones in our hand and giving us everything from FaceTime to Tiger Text, which is this app we use for internal communication around patients, and it's buzzing all day. And so we make sure, we have group text, we have individual text, to make sure that we really know what's going on with everybody. And, we do wrap up the day in the same clinic, and we organize for the next day together. And so and then by the time we reach huddle the next day, we're able to execute on things that needed to get done. We use the EMR inbox to also communicate for things that may not be as time sensitive, but just need to get done. And I think that we build really important and streamlined systems around that, to make sure that, yes, we have things that we need to get done right away. This is what we do. But when we do just need tasks to get done, they happen through our EMR. On the patient facing side, this is where the rubber hits the road. And I think, again, coming down to the people and who we hire and where they come from, I think we have an incredible set of clinical partners that understand the limits of what can be done over the phone versus what needs to happen face to face, to, again, I mentioned setting up transportation for a patient just to get to a visit. That's not even with us. We have a patient that has critical aortic stenosis and needs valve surgery. She went to one visit with the CT surgeon, came back and couldn't repeat back to me what transpired there. And the CT surgeon's office, like, this patient's non-compliant, doesn't want it. And it was clear that there was a communication barrier that wasn't just a second language. This was a health literacy issue. And so we sent our clinical partner with the patient to a repeat visit after I spoke to the nurse practitioner there, and organized everything. And these are the things, when you're not on the clock for, productivity around RVUs, you can really be thoughtful about. And this patient wound up making a fully informed decision. And, I think the challenge is there with, as we exponentially grow, how do we build the same systems to be able to do this for our patients at scale? I think that's something we answer, we're asking these questions every day, but I think it's with hiring more people from the community and more nurse practitioners or physicians. That's my opinion.
So it sounds like if I was to tease out some of the incremental elements to this, one of the key pieces is communications and teamwork. So, if you recruit for that, create teams that are founded on that, you're building out. But the other thing that I heard that was maybe a little bit unique, it's not one that I've heard sort of equivalents of the huddle, that beginning, set the day out. It's a bit like morning ward rounds. It reminds me of the surgeons. They always do their ward rounds first, and then everybody sets off and does things. What I heard was a little bit different with you. You not only do you do that, but you have a catch up at the end of the day where everybody comes back together and says, hey, what have we learned? It's sort of, bring everything back together and say, let's plan for tomorrow. Is that true?
Yeah, the large majority of planning and blocking and tackling tasks around a patient's care, particularly a concerning patient, happens in the morning. But through the day, there is communication that's happening from one teammate to another. But at the end of the day, we do we all come back to the center. We all figure out what's left to do, and we even things to screening a patient for tomorrow that didn't get a chance to be done. Our teammates are helping each other out, and huddle. It's really changed the way we think about just managing what happens during the day, and then on the back end, it's really by coming back to the center, just by being great teammates. We just want to help support each other so we can get off to a good start the following day. And I think it just comes back down to culture and doing this for each other, and knowing what we're doing is just inherently so different from the conventional healthcare system that we feel it's palpable every day, and every person that walks in the huddle in the morning can attest to that.
So for those of you just joining, I'm Dr. Nick, the Incrementalist, and today I'm talking to Dr. Jay Mathur. He's the Associate Regional Medical Officer for Caremore Health Systems in Connecticut. We were just talking about the huddle and the experience of bringing people back together and, the value of that sort of teamwork. So what I was hoping was you could share a little bit of the experience down at the individual level. I know, I heard some of the great stories. I know that there are folks you had talked about, at least one patient who had struggled with an interaction with a specialist, and in a revolutionary kind of idea, wow, send somebody that's an expert with them who could help provide translation, and you had a whole different outcome. It was sort of a binary experience. Are there other sort of elements that you recall in some of the interactions you've had with patients or your colleagues have had with patients where you go, wow, that was really significant. That provided something that, you go home at night and go, that's why I did medicine?
It's a great question. And one particular patient comes into mind. He's a gentleman that's now on hospice at home on his own terms, but he's a 91-year-old gentleman that we began seeing last fall. And I mean, from being on 22 medicines to having a bunch of vascular diseases that, he'd probably outlived his life expectancy by 20 years. But in this current healthcare environment, really he comes from a family and a culture where talking about end of life, talking about advanced care planning hadn't happened, and the healthcare system doesn't give us the opportunity to do it in a meaningful way in a conventional fee-for-service environment. And so, right off the bat, as we found him in the hospital for a urinary tract infection, the gentleman has a chronic indwelling Foley catheter because his prostate is, the largest it can be. And so we introduced the idea of him living at home, which is what he wants, and he's very clearly he suffers from dementia, but he's able to convey very clearly that he does not want to be in the hospital. And while you can have dementia while still being able to convey your wishes, and I think the family was very understanding of that, and just being able to take those incremental steps to not rushing to get a DNR DNI, but to actually talk about what quality of life means at this point in life to him, and then work backwards from there. It took 2 to 3 months, and we wound up having a couple of family meetings. He wound up getting a UTI, and I actually found a local vendor that would initiate IV antibiotics for him. We were able to get that set up in his home, and I'd go in and check on him twice that week that we were administering the IV antibiotics. And we treated the UTI, but the next one is around the corner. And conveying that to the family, like, this is not going away with the indwelling Foley catheter, we were able to slowly just get them to understand what the next curveball coming his way is, and what we could actually do in the home environment to just focus on quality. And so, I now use that vendor for IV antibiotics. I needed to do it out of necessity, and it turned into now a process. So, we were able to deliver on a patient's values. We're able to walk a family along the continuum of what comfort care could look like, and it's not euthanasia, which is what we needed to spend 2 months describing that to them for. And it really, over time, just it was patient-centered, and I felt really good that I met a patient where they were at, literally and figuratively.
So I love that. One of the things that I've talked a lot about is end of life, our inability to really talk about it as a society. It's something that one of my discussions talks about how doctors die differently because we have a different understanding of the medical interventions. We're better at communicating, although in general terms we're not. And for me, that's just such an important area. And it sounds very much like, again, it goes back to the health literacy that you talked about, because when you were discussing this with the family, there was a misunderstanding or a misconception as to what this all meant. And you turned that around to give not only the patient, but the relatives as well, this fantastic experience with the healthcare. And that's essentially what we want to do in medicine. So I just applaud you for that ability and, the solutions that are doing that. As you think about some of the things that you've done, and, you mentioned this a little bit, so I want to sort of push you on this, because I think most people would listen to this and say, gosh, this is great, we love this, but how do you scale this? Is there a way to sort of make this available to more? You're focusing on the folks that need it, rightly so, but is there a way that more of us can get this? Are there parts to this that can be replicated in a way that can scale?
It's a great question, Nick, and it's the $1 million question, or more than $1 million question. But as we think about what scale means, I think about scaling for these types of populations across the country and not just being isolated. We're working on this, and every single person that comes into work every day here at Caremore knows that we are a part of being the first into the future of what healthcare could look like, because we're set up the right way. And if what Caremore accomplishes at the end of the day is what great care looks like once you've aligned all the incentives, I think that is success just from an internal perspective. For me individually, I have a lot of, I'm a believer in, healthcare being, a human right. And if a part of that is just showing what great care could look like and doing it in an environment where we're set up to do the right thing, maybe we make the business case to the government, to other private enterprises, or this is how you do medicine and this is how you pay for it. I think how do we scale just to start doing this for other segments of the population? I think there's a lot of organizations out there that are trying to figure out the right avenue to implement interventions like this. And even to Caremore, we're just trying to figure out, is it the payer space? Is this an employer relationship? Is this through a commercial more? Do we want to expand this into a more commercial population? I mean, I think this level of intervention where we incorporate behavioral health, think about community-based resources and how to engage them. I think that, the kitchen sink, if you may, we may need technology solutions that do the same thing. Maybe you or I have a data plan and can get the same level of interventions through an app and have a data plan to pay for it. But at least defining what the buckets of interventions are. I don't think that those may be very different across populations. So, it's a great question, and if I have the answer to it right now, I go to Washington with it. But
I knew it was a hard question, and that's why I left it till the end, because obviously this is highly desirable. I think it satisfies all the triggers for physicians, for patients, and even from a financial standpoint, because I know that you've shown savings through all of this. So I know it's tough, and it's exciting that it's being successfully implemented here. Unfortunately, as usual, we've run out of time, so it just remains for me to thank you, Jay, for joining me on the show. It's been a real pleasure.
Thank you, Nick. Really proud of the work we're doing here at Caremore, and if you haven't heard about us, you'll be hearing about us soon. Take care.
Thanks for joining me today. Do you have any better ideas, or have you found a small incremental change that's brought about a big improvement in your world? Let's continue the conversation on our hashtag, The Incrementalist, or share with me at DrNick1 on Twitter. You can find more information about the show on our program page at healthcarenowradio.com. And tune in next time to hear my discussions with leaders and innovators from around the globe who've revolutionized their space by using small incremental improvements to achieve their moonshot. I'm Dr. Nick, the Incrementalist, and I'm starting a revolution through evolution.